Patient assessment. National Standard Curriculum is going to apply the information that you gather from every aspect of the call. Scene, the assessment findings, your interview, patient history, everything that you've received at the scene, and everything that you were told before you got there to things that you were told en route. All this is part of your assessment scheme, which is the overall emergency management guide. So when we say that patient assessment is important, patient assessment is everything. It's every single thing that you need to know to be a good EMT, a good paramedic, to be able to talk to your patient, to be able to gather information, to be able to categorize information, to be able to disseminate information, to be able to use that information to make a diagnosis and treat your patient. A lot of your patients might not need advanced care, but some will. And some, without a proper assessment, might be hiding some problems that you wouldn't see if you weren't cautious and careful and precise with your assessment skills. The main parts of the assessment starts, of course, with your safety. Make sure it's safe enough for you to enter. And that occurs when you size up the scene. Then we make patient contact. We do our primary assessment. We get a history. We do our secondary assessment, and we reassess. Those are the 5 main parts, and we'll discuss each one of them at length. So the scene size up shows you how to prepare for a specific situation. And it involves the moment you get assigned to the call. It begins with dispatch information. When you arrive on the scene, you add to what you heard from the dispatcher, and you put together what you see when you inspect the scene. It always starts with your safety. Once your safety is assured, you progress inward and you make patient contact. Determine the mechanism of injury and nature of illness. Okay, simply ask a question. What's going on? Why am I here? Talk to me. Tell me what your chief complaint is. The first thing the patient tells you, that should be their chief complaint. At this point, while you're walking up to the patient, size up. Do we need to wear gloves? That's a standard precaution. Why not? How many patients are there? Do a sweep of the area. Don't just focus on the one person that you see, or the first person that you see. Make sure, especially at scenes where there's possible violence, or there's a car accident, where there could be more than one patient, make sure that you get a good count. And at this point, we want to consider additional resources. EMTs, now would be a good time to think about requesting ALS. Do you need a supervisor? Medics, do we need something like a helicopter? Should we be setting up a landing zone? Do we need more ambulances? Now is the time. Many states require anyone operating on a highway to wear a safety vest. Make sure that you park your vehicle at a safe location that allows you to access the patient and extricate them, but also keeps you in an area where it's safe. You should be able to recognize hazards. If you roll up and see 5 people having a seizure inside a building, don't enter the building. The chances of 5 people having an epileptic incident at the same exact time would be you winning the lottery on consecutive weeks. It's impossible. There's something wrong. Pull back, reevaluate the situation. If it's not safe for the patient or the bystanders, try and move them away. But always ensure your safety first. If the patient is exposed and contaminated, we don't want that patient brought on board our ambulance. We don't want to make contact with that patient until they're decontaminated. Sometimes you'll have bystanders trying to help. They might have the best of intentions, but they're not part of your team. Try and avoid having bystanders assist you with anything but keeping other people back. So once you've established that the scene is safe for you to enter, you've taken your standard precautions, now we can address the patient. If you have a trauma patient, you want to see the mechanism of injury. You want to see what the car looks like. You want to see if the patient was shot or stabbed, what kind of weapon it was, okay, the location. This tells you a lot about the seriousness of an injury. Some systems across this country have policies in place where crews take pictures of accident scenes that they later share with hospital staff. That is a policy that is agency specific. It is not part of the standard scope of practice. And you really can get in trouble taking pictures. Although they can be very usable and a vital part of an assessment to trauma surgeons and the like, but you have to be careful and follow your agency's guidelines for things like taking pictures. And remember, they are part of a patient's confidential care record. When you're doing an MOI assessment, you want to evaluate the kinematics involved. Now, kinematics is the laws of force, and we have different laws. Objects at rest tend to stay at rest. Objects in motion tend to stay in motion. Energy is transferred from one mass to another. So you got to see that force that's applied to the body, the energy from the object that applied the force, the size of the object, the speed of the object, and speed is the factor. Speed matters over anything else. Whether it's a car or a bullet, velocity matters. So you look at the velocity, you look at the object that caused the force of damage, and then what part of the body was impacted. What body system has been affected by the trauma. Now for medical patients, we need to talk to the patient. Trauma is a lot of visual inspection. Medical is all about the interview. So understanding what you're doing, trauma, medical, whether you're talking or not, it's all part of the assessment scheme, but there is a general approach to patient care, and your patient assessment should be universal, regardless of where you find the patient, how they were injured, why they're sick. All of it should start the same way. So our standard precautions, of course, gloves. They've been developed over the years to combat us having to deal with direct contact with bloods and body fluids, because we have bloodborne pathogens that are infectious if they get into our body. So when we talk about standard precautions, it's based on the concept that we just make assumptions that every patient has an infectious disease, because every patient has the potential to have an infectious disease. And the type of personal protective equipment that you use is going to be based on the specific job duties that are required of you as an EMT or a paramedic. So finding out the number of patients after you've assumed your safety and taken standard precautions is vital. Because it's going to take maybe 8 to 10 minutes for help to show up. That's a long time, and you're going to need help sometimes a lot faster than that. So it's critical to figure out when you're going to need help. The best thing about that is you can always cancel it. If you have multiple patients, a mass casualty incident, you're going to have to initiate triage. So you want to, before treating the patients, advise how many units you need, make a general estimate. If you can say 1 ambulance for every 2 patients, that would be a good start. In addition to more ambulances, some systems may need specialized resources, some situations. Fire department, rescue, law enforcement, help with bystanders, a lot of different issues. All that should be handled before we make patient contact. Once we make patient contact, we go through what's known as the primary assessment. And this is your ABC assessment. You got to assure that the patient's airway is clear, they're breathing effectively, and their circulation is good. If there's a problem with one of those airway, breathing, or circulatory issues, you got to correct it immediately before moving on. So it starts with a general impression, and this is where your clinical knowledge comes in, and your abilities. And your ability to form a general impression gets better with each patient contact. This is how you see, make a note of the patient's age, their race, their sex, what level of distress they're in, and overall their appearance. Are they looking like they're short of breath? Are they unresponsive? Or are they sitting packing a suitcase for the trip to the hospital? This is all part of your general impression. Make sure you approach from the front of the patient. Don't sneak up behind them. Note their position. How you found them is part of your documentation. Always introduce yourself and find out what their chief complaint is and get it from them. Now, the greatest thing about the assessment, you can do your full ABC primary assessment by asking one question, and that is, what's your chief complaint? What's going on? Why am I here? What seems to be the problem this evening? If they tell you, I don't know, I've had a headache for 3 days, would you say their airway's clear? I would. Controlling their tongue. Control your tongue, you control your airway. How's their breathing? It looks okay, sounds okay because they're able to speak in a complete sentence. It's also not their chief complaint. That's also a clinical clue. Well, how about their circulation? Well, they have cognitive thought. I asked them a question, they received it, they interpreted it, and they sent me a response. That tells me that there's enough blood going to the brain. So my ABCs can be covered right off the bat with that one question. Of course, part of your breathing and circulatory assessment is going to involve listening to lung sounds, possibly putting on oxygen, checking for a radial pulse, checking skin color, moisture, temperature. Absolutely, but it all starts with the question. So that's known as the level of consciousness. We determine the patient's neurologic and physiologic status. Is it altered? Is it unaltered? Or do they have no consciousness? We like to use that mnemonic AV code. Alert, verbal responsive, meaning they responded to your voice only, and they focus their attention to the sound of your voice. Pain, they didn't respond to your voice, but they responded to painful stimuli. Or unresponsive, when they did not respond to your voice or your painful stimuli. A nice tool that we can use is an orientation test that tests their level of mentation. Are they alert to person, place, time, and event? What this does is it it takes this into a 3-dimension where you can talk to somebody and get a response. That won't always tell you if there's a change in their mental status. But finding out what their long-term memory is, this is a good tool for that. If they know all these facts, they're known to be alert and oriented times 4. Now, if they're not showing any signs of life, instead of the ABC approach, we do the CAB, which is circulatory check first, then airway, then breathing. Otherwise, if they're showing signs of life, it's A, B, and C. So breaking down A, B, and C again, with airway, determine the airway's open. If they're talking to you, it is open. If they're unresponsive, we're going to have to take control of it. Look for signs of airway obstruction. Most common form of airway obstruction in an unconscious patient is the tongue. That's why we like to use oropharyngeal airways or nasopharyngeal airways to control the tongue from falling in the back of the throat and obstructing. If you're concerned about mechanism of injury, you want to use the jaw thrust. If you're not concerned about mechanism, if this looks like a medical patient to you, found unresponsive in bed, for instance, then the head tilt chin lift is appropriate. In addition to relaxation of the tongue, airway obstruction can be brought on by dentures, blood, aspiration and vomit, mucus, foreign body, such as food or anything else. That needs to be addressed immediately. Without your airway, you can't deliver oxygen. You can't ventilate. So without the open airway, there can be no ventilation. With no ventilation, there can be no cellular respiration. With no cellular respiration, there can be no life. So it all starts with airway. You can't move forward until you've corrected any airway compromise issues. Once that's done, now we assess breathing. Make sure it's present and it's adequate. Once again, asking that one question and they answer it without having to catch a breath, they've spoken a complete sentence, that would be a determination that is possibly adequate breathing. But we'd also like to listen to lung sounds. Normal breathing is quiet. Abnormal sounds, you can hear with your stethoscope. You can hear wheezes, rails. You can listen and actually tell that there's respiratory distress with the prolonged expiratory phase. You see a lot with asthmatics and COPD patients. Breathing should be an automatic process that alters with speech, but your speech should be able to finish a complete sentence without having to take a breath. So you check the respiratory rate, the rhythm, is it regular or irregular? The quality of breathing and the depth of breathing. Is it effective? Is it too shallow to support life? What's our tidal volume? So while you're doing this, you're going to ask yourself these questions. Is the respiratory rate too fast or too slow? Is it too shallow or too deep? Is the patient cyanotic? When I listen to the lung sounds, do I hear abnormal breathing? And is there lung sound present on both sides? You can visualize all of the signs of increased work of breathing, otherwise known as respiratory distress. Now, this is a situation where the patient is able to assist in their own care. They're using accessory muscles to breathe. They're trying their best to increase their lung capacity to get more air in. This is a distress issue. This is not a failure issue. So we can assist patients with their respiratory distress by giving adjuncts and supplemental oxygen. When they fail, they're unable to care for themselves, and we have to take over their breathing for them. So looking for these signs of respiratory distress and use of accessory muscles. Patients will be found, like in this picture, in the tripod position. Children don't have those sternocleidomastoid muscles, so they end up becoming, they sniff a lot. They'll have sternal retractions, and they'll also have nasal flaring. Talking is very important. If the patient is talking constantly and they're not pausing to take a breath, they have control of their breathing. Auscultation, like I said, you're listening to wheezing, you're listening for rasp. You're listening for that rhonchi, that's a sign of upper respiratory infections or pneumonias, and stridor, which could be another sign of croup, epiglottitis, inflammation of the trachea. So breathing assessment is complete. It's always good if they're breathing greater than 24 breaths a minute, you give them oxygen. They're breathing less than 8 breaths a minute, you ventilate them. Okay, so you inspect the chest, you palpate, you auscultate, you seal any holes that you see, you stabilize any fractures that you feel, and you give oxygen. I pass gas. Now when we're done with breathing, we go to circulation. Once again, asking that question shows good mentation. Blood is making it from the heart to the brain. But we can also evaluate whether it's making it to the rest of the body as well. And we do that with our skin test, skin moisture, color, temperature. The skin's the largest organ in the body, and it's usually the last organ to be perfused by the heart. So, if it starts to get restricted flow, you'll start to see it get cold, pale, and sweaty. So remember, if a patient has a pulse, but they're not breathing, we need to ventilate them. The ventilatory rate for adults is 12 breaths a minute, and at least 20 breaths a minute for an infant or a child. If you're ventilating a patient and you lose pulses, obviously we're going to begin CPR. So skin color is an important component. And the great thing about that is that we can see it. We can see if a patient is cyanotic, bluish skin. We can feel if they have cold, clammy skin. So we know that there's a problem with hypoperfusion right there during circulatory check. Dry skin is normal. Wet, moist, excessively dry skin, hot skin, that suggests a problem. And once again, take your entire information you've gathered as a scene size up. If you walk in a room, it's 120 degrees and the patient has hot, dry skin, I think we know that there's potentially a problem with hyperthermia, and we have a serious patient that we need to get out of that scene. So all of it plays into your overall assessment. Skin should be warm to the touch, and cap refill on patients younger than the age of 6 should be less than 2 seconds. Don't do cap refill on anybody over the age of 6. During this circulatory check, if we see external bleeding, this is when we control it. We apply direct pressure. We elevate the extremity. And if the direct pressure and elevation is not successful, we think about a tourniquet. Yes, tourniquets are part of the standard curriculum. We're concerned about stopping bleeding to extremities. They're used for extremity bleeding only. Skeletal muscle can go almost 3 hours without blood supply. So we would rather stop the bleeding and deny oxygen to the muscle cells than bleed out and cause the body to die. So tourniquets are used when direct pressure and elevation are not effective. So now we're going to make a determination on whether this is a high priority. Is this a load and go or a stay and play? If there are no problems with the airway, breathing, circulation, the scene size up looks safe, then possibly you can make the determination we're going to stay and get some more information. If this is a situation where you have a problem with the airway, breathing, circulation, any of those three or all three, this is when you make a determination. And load and go does not mean that you throw the patient on a stretcher and run. It means that you increase your sense of urgency that this patient needs to get to the hospital. And whether you're an EMT and you're asking for an ETA for paramedics and discussing how you're going to meet the medics, are they going to show up at the scene? Are we going to take the patient down to the ambulance? Or are we going to have to meet them en route? That's the time you make the discussion. For paramedics, this is the time when we think about doing more advanced care. It may require you staying at the scene a little bit longer, but the goal is to ultimately transport the patient in a stabilized set. High priority patients, like the one on the earlier slide, you add to it, you have patients with severe chest pain, pale skin, complicated childbirth, or uncontrolled bleeding. All of these are priorities that you need to immediately begin the transportation process. Patients who are responsive but unable to follow commands, severe pain anywhere in the body, screaming pain. These patients cannot assist in their own care, and you're not going to get a really good history from them. It's best if you just escort them downstairs, carry them downstairs to the ambulance, and begin transportation. So transportation decisions should be made based on the patient's condition, the availability of advanced life support, what's their estimated time of arrival, and match it. If you're 10 minutes away from the hospital and a paramedic unit is 20 minutes away from your location, then EMTs should make the decision to transport. If the paramedic is 2 minutes out and you're 10 minutes from the hospital, at this point you would discuss where you want to meet the paramedic en route. Should you go down to the ambulance, or are you going to stay upstairs? It's all patient specific. But this is the time when you're going to make that decision and have that discussion. So once we've done our primary assessment and we've gotten our clues from the scene, we're going to start talking to the patient. Or we're going to start talking to the patient's family or anybody else who can give us information, the history of what's going on. Since we're going to walk in there with an open mind and not prejudge anything, we have a blank canvas that we need to have filled. So we need to talk and extract information to build our evidence to make a good diagnosis. So history taking provides the detail of that chief complaint. Document everything, the demographics, the past medical history, the current health status, all important. To find out the past medical history, you use sample. It gives you the signs and symptoms, any allergies, their medications, pertinent past medical history. If they're having chest pain, have they had chest pain before? If they have, what happened the last time they had chest pain? Went to the hospital. What did the doctor say? I was having a heart attack. Okay, that's pertinent. What's their last oral intake? Pertinent because they may be undergoing surgery. They need to know when the last time they ate was, because if they have advanced airway maneuvers, it's possible with a full stomach that there could be aspiration. And then events leading up to what happened. Do you remember what caused this? You were feeling sick this morning. What happened yesterday? What changed? Now, when we do a pain assessment scale, we use the OP-QRS tape. So talking about the pain, when did it start? Anything make it better or worse? Quality, what kind of pain is it? Sharp pain, is it dull pain, squeezing, is it more like a discomfort? Is it radiating anywhere? Is it regionalized, or can you pinpoint it? That's very important because we talk about the diffuse pain. That's known as visceral pain. And visceral pain means the organ is sending out a pain signal. The brain can't interpret that effectively. So what it does is that it sends out a regional type of pain. That's dull, it's not, you can't put your finger on it. Somatic pain is that sharp pain. That's using the somatic nervous system, the tactile, your skin. That's a sign of an external pain, musculoskeletal pain. Okay, but is that the gold standard? No, there are exceptions to this rule, but just understand that internal pain is usually spread out. It's regionalized, whereas somatic pain, musculoskeletal pain is pinpoint. If you have sprained your ankle, okay, you would know exactly which ankle you sprained. You wouldn't have pain in your wrist. Severity, we talk about, is this some of the worst pain you've had? Some people like the scale of 1 to 10. Now's a good time to use that scale. There's other times to use it. I like using the scale during reassessment. Some people, they classify it a pain, they can live with a 2, other people look at the same pain as a 10. It's hard, it's more subjective. I like to say, okay, so when I got here the pain, let's say, was a 7 out of 10. What would you say it is now? They tell you, well, now it's like a 5, it's getting better. And they go, no, it's a 9, it's getting worse. But at least you give them a reference point. When we talk about timing, this is when we say, has it gotten better or worse over time? Is it cascading up and down, or is it pretty much constant, or has it been getting worse? When we're doing our history, we want to look for pertinent negatives. Okay, and that's important. You know, ask if somebody has a headache, do you have any problems? Can you wiggle your fingers and toes? Yes, that's a pertinent negative. They don't have neurologic issues with this headache. And we have to gather as much information as we can. Some of this information is sensitive, private, and in some circles embarrassing, especially if you ask somebody if they do recreational drugs or they smoke. But, you know, it has to be asked. But there's a time and a place for it. And usually the place is in the back of your ambulance, and the time is when you're alone with the patient. That's when you're going to have probably the best chance of having a truthful answer. But remember, you got to balance the story, because some of this information is not reliable. You just have to know which one to trust and which one not to trust. When you're dealing with a patient who's been the victim of violence, domestic abuse, you need to be able to report your findings. There, in New York State, we're mandated reporters for child abuse. Other states are mandated reporters for child and elder abuse. And then there are some states that are mandated reporters for any type of abuse: spousal, child, and elderly. So, depending on what region, what state, what policy you follow, bottom line is you need to document your findings. Look for clues. Never make an accusation. You can suspect somebody. Pass your suspicions on to law enforcement. But we don't make accusations. Because if we make an accusation and it's found later to be false, we can be guilty of slander if it's spoken, or libel if it's written. But if you suspect, there's nothing wrong with suspecting. Another private issue you want to get into is sexual history. Okay, if you have a female patient who's experiencing abdominal pain, it's important that you find out if they're sexually active, because it opens up a lot of other medical issues like ectopic pregnancy. So finding out if they're sexually active may be embarrassing. They might not want to tell you in front of the parents, especially, but once again, something that can be done alone in the back of the ambulance. Even though we're in an emergency setting and time is of the essence, there's always room for patience. Be patient of your patient. It's extremely important. If the patient doesn't want to talk to you, there may be a reason why. It could be physiologic, it could be psychiatric. We don't know. So at that point, you're going to have to use closed-ended questions to draw out information. Even though you want to avoid using closed-ended questions, you're going to have to use them in this case to get out as little information as you possibly can. Inversely, you have the talkies, okay? This could be their normal mental state. This could also be an altered state brought on by drugs, stimulants of some kind. That's fun. Once again, patience is a virtue with these patients. Geriatric patients, because of their chronic underlying medical conditions, may have multiple complaints. They can have a chest pain, shortness of breath, and a headache. There could be major issues going on. They also don't present exactly pinpoint like a textbook presentation. If you have an elderly patient who's short of breath, they could possibly be having a heart attack. They could be having an MI. The only way we're going to find that out is if we do more diagnostic testing. So they're poor historians in the fact that their neurologic status could be impaired. Because their neurologic status is impaired, they end up having problems with pain reception and visceral pain that you have in an MI. But they have everything else. So for EMTs, you have a patient with shortness of breath that's elderly. They have a history of cardiac problems. This is a patient who needs more advanced care. Paramedics on scene or a priority patient transport to the hospital. For paramedics, if you're going to do an EKG on this patient, do a 12 lead. They could be having a myocardial infarction, and you might not even know it because they're not complaining of chest pain. This is the challenge. When you have these patients that aren't giving you a good history, you're going to have to spend less on their storytelling and more on your diagnostic equipment. Patients with anxiety, they get pale, cool skin sometimes, short of breath, numbness in the hands, dizziness and lightheadedness. But anxiety looks a lot like pulmonary embolus. You don't know. So never make a quick snap to judgment. Just because this is a 17-year-old who's having an anxiety attack and she's broken up with her boyfriend, she's short of breath. What exactly is going on? We don't know. We have to dig a little bit deeper. You find out that her boyfriend broke up with her because she was in the hospital for 3 weeks because she fractured her femur and now she just can't catch her breath. Wow, if you didn't ask those extra questions, you might not realize that she flipped a clot and is having a pulmonary embolus. So patience and getting the right story and the whole story is vital. You're going to be showing up to someone's house and making contact with somebody who is having quite possibly the worst or last day of his or her life. And in a situation like that, there's going to be anxiety. There's going to be, it's going to be emotional. There's going to be families who are not able to deal with their emotions in a professional way that we are, and are going to lash out at you, are going to be insulting to you. And this is just something that comes with the job, and we have to maintain professionalism. But when that type of behavior becomes dangerous, we need to pull back. We need to involve law enforcement and then re-enter and re-establish the scene. There's real aggression, and then there's that potential for aggression. Intoxicated patients, alcohol, drugs, have a tendency to change their mental state at a drop of a hat. So we have to be aware of that. There is a high potential for violence that can occur at any time for any reason. Anything can trigger violence in these patients. While alcohol can dull a patient's senses, it can also make them extremely violent. Crying patients are emotionally overwhelmed. Once again, this may be the worst day of their lives, and they have not had the training to handle stress management. That doesn't make them a bad person. It just means that you have to try and calm them down in order to get a good assessment. One of the leading causes of disability in the United States is depression. And depression is basically anxiety focused inward. It's the feelings of sadness, hopelessness, you're not happy in your own skin, you're irritable, restless, you can't sleep because you have that inward anxiety. Okay? There's somebody in there, they want to talk to you. You just have to be able to listen to them. Now, just because someone's having a confusing behavior doesn't mean that they're a psychiatric patient. That's all the way at the very bottom of our diagnostic tree. We have to rule everything else out before we just say, hey, you're just plain crazy. All right, so it starts with airway and breathing. Hypoxemia can bring on a change in mental status rapidly, within 30, 45 seconds. We don't know why or how it started, okay, but we just know that they're hypoxic. The way we can address that is with oxygen. Okay? Other things that can bring on confusing behavior, non-traumatic brain injury or traumatic brain injury. You can have an elderly patient who has a sudden change in their mental status. And during your assessment, you find out that they fell yesterday and hit their head. Is it possible that they're having a subdural hematoma? Absolutely. These things are slow to manifest, but when they really take on a clinical appearance, that's when the patient looks confused. So getting a good history can tell you a lot. There are patients that have limited cognitive abilities. They're developmentally handicapped. These patients are usually accompanied by guardians, and the guardians serve as their caregivers. And the thing is, while they might be impaired, the family members are usually high tech. They have more knowledge of this patient's disability than any attending physician at the ER. So we don't want to push them aside. We'd like them on our side, and we want to get information from them and have them assist in the care of the patient, because they're usually the ones who called. They just need a little assistance. We're here to provide that for them, but we don't have to take over all care unless it's a situation where the patient's in critical condition. But for the most part, they just need our help, and we can use them as part of the team because they have the most knowledge of the specific impairment. This is the same also for interpreters. You go to a house where a foreign language is spoken and neither you nor your partner can speak it, that doesn't mean that you've lost all abilities to interview your patient. Find interpreters. There should be a bilingual person in the house. If not in the house, a neighbor. But the best person to find, who you know is going to be bilingual, is one of the children. The children especially the ones that go to school, speak the family language in the house, but they also speak fluent English, and they can interpret for you. Another great thing about having a child interpret for you, they'll tell you a truthful story. They'll tell you everything that mommy or daddy told them. With hearing problems, talk right next to the patient, face to face, talk slowly and articulate your words so they can read your lips, or write down questions and have them answer. Visual impairments, try and stay focused in the center. Don't enter through the periphery or lose sight. You can use tactile therapeutic communication and hold their arm to direct them, to guide them, and explain everything that you're doing through the process. So after your history taking, after your primary assessment is done, and you've corrected any life threats, and you've done your history, now we're going to do a secondary assessment. Now, secondary assessment can be a full body assessment. if you want to gather more information. Where do you find this? Trauma patient or an unconscious medical patient. You want to do that head-to-toe exam. You can do this at the scene, before mobilization, or en route to the hospital. When you assess vital signs, remember, use your appropriate monitoring devices. A new tool for EMTs, an old tool for medics, excellent tool to determine hypoxia is a pulse oximeter. The number should be between 95 and 100%. Pulse oximetry is going to measure the oxygen saturation at the capillary level. Where do you have exposed capillaries? In your nail beds. So under your fingernails are your capillary beds. You put this device on there and the light will sense the presence of oxygen-rich hemoglobin. What percentage of hemoglobin has oxygen? And it will give you a number. 95 to 100 is optimal. In addition to pulse oximetry, we have capnography, end-tidal CO2 detection. You need to breathe in oxygen, but you also need to get out carbon dioxide. Carbon dioxide is created solely in the body as a waste product of cellular respiration. The cells take in oxygen, they create ATP through the Krebs cycle with sugar, and they off-gas, exhale CO2. Now we have to get rid of this CO2. So that's done through exhalation. And end-tidal CO2 monitoring will be able to tell you if you have good cellular metabolism. Normal range for end-tidal CO2 is 35 to 45 torr, T-O-R-R. So 35 to 45 torr pressure is the correct end-tidal CO2 to show that the body is operating at the correct cycle. Anything greater, and there's excess CO2. Anything less, and the body is not producing CO2, which means that the cells are hypoperfusing. So 35 to 45 millimeters of mercury, the torr pressure, is the equivalent to 5 to 6% of CO2. They have colorimetric devices which are used right after intubation, and as litmus paper that changes from purple to yellow. And we also have the newer ones is the waveform capnography, which is read by cardiac monitors. What's big now are non-invasive blood pressure measurements. The automatic blood pressure cuffs should be part of your toolbox. But never forget to be able to take manual blood pressures with a stethoscope. So, who needs a full body scan? Does everybody need a full body scan? Not really. If you have a medical patient who's suffering from the flu, or is having chest pain, having an asthma attack, something that's focused to one area, we don't really need to have them wiggle their fingers and toes and strip them naked and check the whole body. That's not appropriate care. Okay? What a full body scan is for someone who's unconscious, and we've got to find out why, and a victim of multi-system trauma. So we assess all anatomical regions. We start at the head, and we check the eyes, ears, nose, go down to the neck, the chest, the abdomen, pelvis, extremities, and roll them on the back, check the back. Very important to check the posterior. We use a mnemonic in the classroom setting to aid in your assessment tools. It's called DCAP-BTLS. And what does it stand for? Deformities, contusions, abrasions, punctures or penetration, burns, tenderness, lacerations, swelling. So we do that full body scan, looking for all those things that you found in the mnemonic decap ETLS. For all your other patients who you're getting a history from, who have a focused issue, then we do a focused assessment. So this is going to be based on the chief complaint. And the goal is for you to focus on that problem in hopes of correcting it, or at least diagnosing it correctly. So a focused exam on the respiratory system, for example. Expose the patient's chest, look for signs of airway obstruction, inspect for symmetry, listen to the breath sounds, measure their respiratory rate. And then after you begin treatment, after your sample history and your OPQRST, find out their medications, their allergies, and you start treating them, and we do a reassessment to see if there's been any improvement. Cardiovascular system, same thing, focused, vectored to trauma to the chest. You're looking at signs of hemodynamic instability, which is part of the cardiovascular issue. So blood pressure, pulse. Check the skin, checking for perfusion. Compare distal pulses. Listen to heart sounds. There should only be two sounds, lub and dub. That's sound one, sound two. Neurologic, now we want to think about, checking the extremities for good motor and sensory. Maintain, keep checking for the patient's level of consciousness, keep talking to them. The best way to do that is just keep talking to them and see if they respond back to you. And if there's changes, you can mark them. In addition to their mental status, in a neurologic assessment, you're going to have to look at cardiovascular stuff as well. So keep taking blood pressures, pulse, check for skin, check your eyes, that their pupils are equal and reactive to light. If you suspect a stroke, we do a stroke assessment. We test for symmetry, facial droop, and arm lift. And just to review this, I'll go back real quick. When you do that assessment for symmetry, you have the patient close their eyes and raise their arms to chest level. The reason they're closing their eyes is because we don't want them to use other nerves to cheat and level out. When their eyes are closed, they should be able to level out their arms at the same level. If one is a little bit lower than the other, they have weakness on that side. For facial droop, you have the patient smile or stick out their tongue, and you'll be able to tell right there. And we also have, for speech, you ask them to repeat a phrase after you, like, "You can't teach an old dog new tricks," or any other phrase that you want. You want to test for speech impediments that never existed before. Musculoskeletal, we look for the posture and look at the joints and make sure there's good range of motion. Always compare the right side to the left. You want to make sure that it's equal. Assessing the head, neck, cervical spine, palpation is key. Checking the patient's eyes. Looking at the color of the sclera. Is it red? Is it yellow? With the patient's cheekbones, are they in place? Is there any fluid in the ears or the nose? Check the maxilla and mandible jaw, make sure they're compliant. If the patient's moving and speaking, then they are. You're doing a chest check for trauma, you do the I-pass gas. Inspect, palpate, auscultate. If you see any holes, you seal them, and if you're feeling fractures, you stabilize them. Abdominal exam, palpate the front and back. If the patient has pain in the right lower quadrant, that is the last area you check. Check all the areas first and then that. You can end up having diffuse pain and then you'll lose if you go to the first area that's painful. You do that first. Once you do your interventions, you want to reassess. The easiest way to do a reassessment of the ABCs is to talk to the patient. How are you feeling? Are you feeling any better? That's a good repeat of the primary assessment. If the patient's in critical condition and they've been intubated, they have ALS airway control, you have an IV in place, you have a cardiac monitor on them, you want to check, make sure that you still have good breath sounds. Your end tidal CO2 was within normal limits of 35 to 45 torr, and you have good pulse oximetry, so that's good. All right, so keep doing the reassessments. Reassess all of your care that you've given, whether it's BLS or ALS. And look for trends. Are they getting better or are they getting worse? You know, ask the patient in terms of their chief complaint. Am I helping you? Is this treatment helping you? Has it gotten worse? Right? And is there anything new that's going on? Doing vital signs on an unstable patient, it's once every 5 minutes. On a stable patient, it's once every 15 minutes. And what does that boil down to? Okay, so your initial, you have an unstable patient. Your first blood pressure, your first set of vitals are done upstairs. Then you get the patient down in the ambulance. That should take about 5 minutes. Before you go, you take another set of vitals. Then you go to the hospital. As you're pulling into the hospital, you take another set of vitals. So there's your once every 5 minutes. For a stable patient, you take a set of vitals at the house, you get them into the ambulance, you start transporting on the way to the hospital, or as upon arrival, you take another set of vitals. There's your 15 minutes. Bottom line is, if you use this as the overall approach to patient care, every patient is seen exactly the same, and you continue doing this, and your patient care, you have more patient contacts and more patient contacts, it'll become part of your mindset, part of your clinical abilities to work as an EMT or paramedic. Okay? Thank you.